So Dr. Nandan is going to talk about a rare case of eyelid abscess and orbital cellulitis following acute dacryocystitis. Welcome. Over to you.
Good morning, everyone. Thanks to AIOS and BOS for giving me opportunity to present a case on rare case of eyelid abscess and orbital cellulitis following acute dacryocystitis. Our 28-year young man presented in our medical college emergency department with pain and swelling in the left eye since 3 days. As we can see in this picture, on ocular examination, best corrected visual acuity was PL positive in left eye, proptosis was 3 mm, eyelid was swollen, tense and erythematous, extraocular movement was restricted in all directions, conjunctiva was congested, right eye was normal. In pupil, RPD was present, iris normal color and pattern, right eye was normal. On systemic examination, he was febrile, having temperature of 101 degrees Celsius. He had past history of watering and discharge for 6 months in the left eye, and he had undergone a DCR surgery left eye 1 year back. Patient was advised higher IV antibiotics, meropenem, amikacin and linezolid. In emergency, left eye cantholysis and canthotomy was done to release the orbital pressure and decompress the orbit. Patient was asked for MRI orbit left eye. In MRI, on coronal and axial section of MRI with contrast, enlarged left lacrimal sac and preseptal inflammatory changes consistent with acute dacryocystitis with preseptal cellulitis was seen. On day 3, 2-step incision given on day 3 in lower eyelid abscess to drain the pus. Following pus drainage, it was sent for culture and sensitivity. Redness and swelling decreased gradually, tenderness also decreased. Eyeball movement was present in all directions on day 4 but less in lateral movement of left eye. On day 6, patient was discharged and asked to follow up after 3 weeks. After 1 month, no pain and redness was there. Vision was 6/6 in both eye. Extraocular movement normal in all direction in both eye. RAPD was absent. Both eye fundus was within normal limit. So we come to the discussion part. Dacryocystitis is an infection of lacrimal sac secondary to obstruction of nasolacrimal duct. Acute dacryocystitis develops when bacterial growth occurs in the stagnant tears in the lacrimal sac. The infection spread to lower eyelid tissue, forming a preseptal cellulitis. Orbital abscess and cavernous sinus thrombosis is the worst complication that can happen after orbital cellulitis. Orbital cellulitis responds to systemic antibiotic therapy and surgical drainage without permanent optic nerve compromise. Dacryocystitis present with preseptal cellulitis and not orbital abscess due to the insertion of orbital septum on the posterior orbital crest. Other anatomical structures such as lacrimal fascia, medial canthal ligament and orbicularis muscle also act as barrier. If this barrier breaks, orbital abscess will form and lead to vision loss, which requires surgical drainage via opening the lamina propria endoscopically. Preseptal cellulitis is relatively rare, but the infection of the subcutaneous tissues anterior to the orbital septum had a potential to the spread. Thank you.
What was the result of your culture sensitivity? You didn't mention, and did you change your antibiotics? Which organism do you think would cause
Ma'am,
such
as antibiotic was started earlier, ma'am, so no culture sensitive was reported.
No, you said that you sent swab.
Yes, ma'am, I had sent for, but as antibiotic was started earlier, ma'am, amoxiclav, he was going on amoxiclav.
That is always started, but you wait for the culture sensitivity and you can change over later.
Ma'am, but it took 2 days, ma'am, to come report, ma'am, for report.
Okay. And you are confident that it was preseptal, as you were saying?
No, ma'am, it was orbital. Ma'am, on the MRI, it was orbital cellulitis.
Cellulitis only.
Yes,
because there was lot of ocular movement.
Yes, ma'am. Extraocular number proptosis was there, ma'am. Fever was there.
Good presentation.
Thank you.
Yeah.
Thank you, ma'am.
And yeah, so culture sensitivity is again I'm so happy that you took the effort to send the abscess for cultural
Yes,
sensitivity, because most of the time it's ignored. You know, when a
Yes.
patient comes in an emergency acutely, the only thing that as a clinician you just think, you know, is to just drain the pus. So it's so very important. Now that everything fell in place in your case, okay, it may not be the same in many other cases,
Yes, ma'am.
right? It may not respond to the antibiotics,
Yes.
then you're beating your head. So the pus is so valuable.
Yes,
So
ma'am.
always and always, whenever you drain out a pus from any part of the body, send it for culture and sensitivity.
Thank you, ma'am.
Yeah, just a comment. So, whenever patients with an LD block come in and say that many patients defer surgery because it's not sight threatening
Yes.
or life threatening. So, I think as oculoplastic surgeons, we always explain that there is a possibility of acute infection,
Yes.
and that acute infection can go back
Cavernous
into
sinus.
the orbit, and
Yes.
at rare occasions
Cavernous
can be more
sinus.
serious.
Yes.
So I think that's one thing that we should not treat it as a trivial thing wherein you will just have some watering. We must explain to our patients and motivate them to have surgery as well. Yeah?
Thank you, sir.
Just a question to the residents. Supposing I feel that it's a case of infected sebaceous cyst, how would you contradict me?
Pardon, ma'am.
Supposing I say it's a long-standing sebaceous cyst, just looking at the clinical picture, and it's an infected sebaceous cyst, would you like to contradict me? And if yes, how?
Process was there, ma'am. Extraocular movement was restricted in my case, ma'am, and fever was also there, ma'am. And
Anything
ma'am,
else?
RAPD was there, ma'am. So we could we were thinking about the optic nerve compromise, ma'am, in this case.
And most important is the location. If it is
Yes.
an NLD infection, we usually see whatever it is, whether it's a tumor, whether it's a infection, is below the MPL. Anything above the MPL. Very recently, I got a case which was diagnosed in multiple places as NLD lesion. But the moment I have seen the patient, I could see something above the MPL. So then we have done a CT and we have done a biopsy, and it came out to be a tumor. So you should be very careful. You should be very, very careful. It was a tumor which was involved and coming from the frontal sinus. So anything above the MPL, just give a second thought that can it be something besides NLD lesion?
Nandan, one question.
ma'am.
Maybe I just missed it. Did you give steroids to this patient?
No, ma'am.
Okay, yeah. So this is just open for a discussion for a
Yes, ma'am.
panel and the audience over here. So whenever the patient presents with orbital cellulitis, you know, like in my practice, I do give steroids,
Yes, ma'am.
oral steroids,
Yes.
especially when there is an optic neuritis
Yes.
component and
Yes,
an
ma'am.
optic neuropathy. So definitely with antibiotic coverage.
Yes,
So
ma'am.
the first 3 days we start with IV antibiotics or oral antibiotics. And if there is severe orbital cellulitis, because we don't want the tissue recovery to take longer. There are
Yes,
muscles, there are many, you know, sensitive structures, anatomical
Yes, ma'am.
structures in the orbit, and optic nerve,
Yes, ma'am.
right? Yeah, vision is so important. So steroids is something that I would have added in this particular case. So over to you.
Right. I mean, if one is very confident, like this kind of an acute presentation where fungal etiology is more or less
Yes, ma'am.
kind of ruled out, then I think steroids with cover of antibiotics. Start the antibiotics before, start the steroids a little later,
Yes.
always covered. I think that helps in the recovery tremendously.
Thank you, ma'am.
Ma'am?
Nothing much to it. I prefer doing a blood culture in such situation. Any case of infection is a long standing. Only if the blood culture is negative, then definitely steroid to be added.
All right. Any comments from the audience? Anything to add on? We have mics there actually. This is basically a discussion, interaction.
I'm not very confident about the steroid aspect, but yes, I agree with Feroz that we do need to look at the tissue damage, long-term tissue damage. So maybe after 48 hours, if the patient is responding to IV antibiotics and there is inflammatory components, then I would add a
Yeah.
steroid.
So I add after the third day of, yeah.